Okay, so I'll begin. About my disclosures, just the usual ones, except I negotiated with the foundation, and they're going to give me a 1953 Jaguar XK120 instead of the honorarium. I'm going to be talking about the Lidcombe program, and I also have my PhD student down here because she is a major help with this. She's just a real crackerjack Lidcombe clinician, and if there's time, she may try to fill in any gaps that I've left. But in any case, we've been using this program since about the year 2000, and it's a parent-delivered, as you'll see, preschool program for kids who stutter. It was interesting when we first started to use it. There was a professor at Midwestern University who, when he read about the Lidcombe program, he declared it was the devil's work. And soon after we were using it, I was at an ASHA, and a couple of guys came up whom I know fairly well, and they sort of towered over me, which isn't that hard, and they said, is this true that you're using the Lidcombe program? And I thought they were going to break my arms, but it turned out it was sort of an indication of the fact that whereas Lidcombe is very widely used in Australia and many, many other countries, probably 15 countries around the world, our perception is that it's not widely accepted, especially in the academic circles in the United States. And so we're working to try to change that. I think we're in a really good place to do some implementation research, because a lot of the RCT sort of work has already been done by the Australians, it's called the Australian Stuttering Research Center. So I want to begin by just describing the program and then going into the background of how it was developed and the RCTs and other studies that the Australians have been doing, including a really nice implementation study, the first implementation study ever done in the area of stuttering. That was done, published last year. And then a little bit about the work that Dana and I are doing at the University of Vermont and heading toward the implementation study that we would like to do. And we would love your input on, some of our ideas about how we do the implementation. So this is sort of the flow chart of Lidcombe. It begins with a clinician meeting with a parent, and that goes on weekly or fortnightly. And the clinician's job is to support the parent and teach the parent the program. And then the parent takes it home and works with the child in what are called structured conversations every day of the week, 10 or 15 minutes to start out in these highly structured conversations, which might be, like naming pictures or playing a game where the child had a short response. And then it moves to more unstructured situations, like, if the parent or caregiver is alone with a child, that works best rather than having other kids around, but it's done, in the car, in the grocery store, in other places. So that I think some of the magic is that the treatment is done where you want the generalization, because these are preschool kids, and of course you want it at the home, and then you want it in other places that the child is normally hanging out. And this last little icon is showing how progress is tracked both by the parents and by the clinician. And so I'll show you an expanded version of this severity chart, but it seems to be an important element. So just to highlight and reiterate, it's parent-delivered, and the sort of engine behind it are verbal contingencies for stutter-free speech during those, let's say, at the beginning, structured conversations in which the parent and child are looking over a picture book and the child is naming the pictures. And then, not very frequently, but like every 5 times a fluent utterance is praised, a stuttered utterance is, we usually call them requests for correction. I know in Western Australia, I learned that they call them pickups. And so an example would be if the conversation is going on and the child stutters on a word like truck, the parent, in the most upbeat way, just says, "Could you say truck again?" And the child most often will say it fluently, and the parent says, "That's great, that was really smooth." And so the praises need to be varied because they need to be reinforcing. And so, that was really smooth talking, great talking, that was wonderful. And so the model that the clinician gives the parent is a very sort of upbeat model. So we'll talk about the fact that that's this whole thing is fun for the child. I asterisked, if that's a word, the verbal contingencies, because it's got to be adaptable for the particular family you're working with and the culture. It was developed in a Sydney suburb called Bankstown, which was a very immigrant-rich environment, but people were coming from all sorts of cultures. And I don't know, I'm sure you've experienced this, but you go to Europe or some other country, and people are so puzzled with your praises, like "have a nice day." Well, this is not done in the rest of the world. Or those little smiley faces we make. So people often say that that those verbal praises are not as universally accepted, and so it's a very flexible program that has to be adapted to what the child and the family are comfortable with. So the Australians were giving me some examples of some people from Arab cultures. All they were willing to do is just do a thumbs up or a nod or a wink or something like that, and some other signal for "say that again." So I just want to emphasize that the flexibility within the core principles is a very important element of the Lidcombe program. I might say that this element of working with the child and actually saying something about the stuttering is one of the sticky points. That is, it may be why it's had difficulty being accepted in the United States, because in the 1950s, some of you may know that there was a clinician named Wendell Johnson. He had the diagnosogenic theory. He thought that one of the things that causes stuttering is when a parent inappropriately thinks normal disfluencies are stuttering and calls attention to them, or has some facial expression that disapproves of them, and then stuttering starts. And so I think the reason that this academician called it the devil's work is he was convinced that this would just make stuttering worse. And you'll see in some of the studies that I'm going to talk about that it was an effort to show that this was really not the case that motivated some of the work. So as I said, it begins in a one-on-one structured conversation, progresses to daily unstructured conversations, and again, this is sort of like need to be adapted to the family, because a lot of kids want the structured situation that's daily. It's like, if you've ever been in psychotherapy, it's nice every Monday afternoon you're going to go see your therapist, and that's reassuring. And so kids love it when they have the total parent attention at the same time every day. But we try to move it over into sort of situations that that fluency needs to be generalized to. Oh, I forgot to say that I have a conflict of interest because I stutter. Anyway. There are weekly or fortnightly. That's the British version of biweekly, but we can't say biweekly because does it mean 2 times a week or once every other week? And that is a major, that could be a major problem, as I'll talk about. And this is important, that the clinician demonstrates to the parent, I'm sorry, I got that backwards. The clinician asks the parent to demonstrate what they're doing at home with the treatment. So they can be at different stages of the treatment. Sometimes, probably most often, we begin with just praises. And Dan, nod your head if this is what you do. And then, very soon afterwards, you introduce the pickups. But you really need to know that the kiddo is comfortable with the praises first, and then the pickups, and you need to know that the child is comfortable with the pickups. And so you're monitoring this, and so as Dennis Embry said, you're looking for, sort of forgotten his phrases, but like, is there any harm? And so when the parent is demonstrating the treatment, you're seeing, is there fidelity in what's going on at home? with what you're hoping is going on at home. And so you have these severity ratings that are done. I have my pointer here, and I was going to use one of these, but I'll throw that out because I find that if I do use an electronic pointer, I go make all these circles, and it's totally distracting. So this scale was developed by the Australians and shown to be valid and reliable for clinicians to teach the parents to use for the daily ratings. And so 1 means typical fluency for that child's age. 10 is the worst stuttering that a parent could imagine their child having. And it's funny that it never seems to be a big issue. Most kids start out somewhere between 5 and 7 in terms of the severity. But the clinician is sort of always checking on the agreement between what they think the child's rating might be in a, let's say, usually at the beginning of the session you have a period of about 5 or 10 minutes in which you are recording the child and you're sort of making an online judgment about the fluency. And then when that's over and the child is still in the room, you're saying, the clinician says to the parent, what number would you put that on? Like what number would you give that for the severity rating scale? And then the clinician said, well, I would give it a this. And if there's more than one number difference in the severity rating scale, then the clinician works with the parent to get them on the same page, as it were. But this is done with the child in the room. And so this is another element that was very different from the way I was trained. I mean, as a person who stutters, you can imagine how, and who's been doing very hush-hush kind of therapy where I'd take the parent to a different room if I were talking about the stuttering. It was hard at first just to be talking about stuttering openly with the child there. But what a relief it is to find the child is fine with that, because it's just like, oh, you banged your knee when you fell off your bicycle, or just some very mild thing. And so it takes the negativity out of it. It sort of normalizes the stuttering, as it were. There are 2 stages of Lidcombe treatment. First stage is usually takes about 15 clinic sessions. It goes until the child is essentially stutter-free, and the criterion for stutter-free is 3 weeks in a row, in which of those, like each 7-day week, the average of the severity ratings are 2 or below, and at least 4 of those 7 days are 1s. And that's got to be 3 in a row. And so it really sort of gives you the sense of there being sort of stable fluency. Stage 2 is, I don't know why, but the Lidcombe developers really didn't like to call it a maintenance stage, but that's what I call it. And it's fading. And it's fading of the number of, like, do you have the session every 2 weeks, and then maybe you begin to fade that, so it's only every 4 weeks and 8 weeks and 16 weeks. At the same time, the parent is fading the amount of praise and pickups that they're doing, so that the child begins to maintain the fluency without that. And in those first 3 weeks is when you're most likely to get the relapse. And so parents will decide to come in more regularly, or because it's parent delivered, the parents feel that they are having this beneficial effect. It's not like I've got to go back to the clinician. So actually, most of the time we hear from parents that their child relapsed last week, but they knew just what to do. And because stuttering runs in families, if the first child is treated with Lidcombe and the second child starts to stutter, sometimes we don't even hear about it until later, when the parent has just figured out, how they're going to deal with the situation. So, the way we're trying to disseminate it is through training. It's a two-day training, and this is where Melissa Bruce and Julie Revel and I started, and what Danner has done also. And so, so this is part of the whole Lidcombe approach. And then in the United States anyway, thanks to Judy Custer and the Stuttering homepage, she introduced the listserv And so we're often hearing from people all over the country and sometimes all over the world about issues that they're having when they first start doing Lidcombe. And so as soon as somebody writes something, myself or Danra or Rosalie or one of the many consortium members will get on there and make some suggestion, and then experienced clinicians who are not consortium members will pop on there as well. So let me go back to the history of the development of Lidcombe. Essentially, in the 60s and 70s, clinicians started using operant conditioning through verbal and nonverbal contingencies to reduce stuttering. And it was a lot of that was single subject design, and it was sort of coming out of the Kansas model. But that's the Minnesota Gopher, because University of Minnesota, Dick Martin, Sam Haraldson, and people like that were doing a lot of studies, including the famous puppet study that came out in '72, in which they had three or four single subject design things where the kids were watching a puppet show, and when the kids stuttered, the puppet show would go dark, and then it would stay dark for several seconds, and then it would come back on. And some of the kids actually said, "Hey, Susie Bell, goes dark whenever I stutter," or something like that. And so these kids were followed up, and it was found like it was quite effective. Roger Ingham, who was an Australian, was doing a postdoc in Minnesota at the time, and got quite interested in the operant methodology. His student, Mark Onslow, who was at the Lidcombe Hospital, which looks like that, or at least it did back in the 90s, tried the puppet show idea, and that didn't seem to work, and he sort of played with a few things. His background, for those of you who know Mark, this won't surprise you, but his background is in theater, and so he went to the National Theater, as did all those Australian actors like Russell Crowe. But after he graduated and tried to make it in National Theater, for some reason he got, it wasn't as lucrative or successful as he thought, so he thought, well, I'll be a speech-language pathologist. And so that's where the big money is. So he was, wonderfully animated as a clinician, and developed with a couple of other people a treatment program that was parent-delivered, and it really started to work. And so they did experiments and refinements that they didn't publish, but they learned that the program has to be highly supportive. So if you think about the puppet example, it's just punishment. But they realized that praise was really important, and so that's probably obvious to us all now. But and it's not only the verbal contingencies, but the whole deal has to be a lot of fun for the child. In other words, it can't be too serious, it can't be too glum. It's play-based, and so the kids got to be looking forward to it. And that ratio of positive to pickups is high, and the SRs, the continuous assessments, seem to be important. Now, I'll quote one study that maybe wasn't so sure. In any case, the initial research was obviously efficacy studies. So at first there were 3 non-randomized phase 2 trials, and then there were 2 phase 3 randomized controlled trials. So the Jones et al. Study was in New Zealand because they wanted to get a country where it wasn't as widely used. Because I don't know why, but when we lived in Australia, it was amazing. Like, one person would get a Sony VCR, and everybody in Australia would get the exact same thing. And so, pairs of pants or the kind of surfboard, it just like spread like wildfire. And so I think maybe that was, why Lidcombe was easily adopted in Australia. Tina Latterman came over to Montreal, and she studied with us for a while as well. She's from Germany, and so she, learned about the Lidcombe. Then she went back to Germany and worked with Katrine Neumann and Harold Euler to do her PhD dissertation, which was a randomized control of Lidcombe. Apologies to, I think your name is Berta, if you're Berta. Anyway, you're probably in the audience. But in any case, Tina's report of her own native Germany was The resistance was because the German parents didn't think play was a good idea. And, you know, like education needs to be drill work and very serious. And also, the German parents objected to the use of plastic toys. They thought only wooden toys should be used, and that was what Tina had learned Lidcombe with. And so she was able to make adaptations and work quite successfully, and I think it's quite widely used in Germany. So Jones et al. Did a follow-up, like a 3 to 5 year follow-up of the kids who'd been in that first RCT, and found that they were quite well, you know, that their fluency had stuck. That's what I'm trying to say. So, you know, there's so much objection to the idea of punishment, and a well-known center in Europe just were writing all sorts of negative reviews of Lidcombe, even though they weren't using it, but they're saying, you know, this makes the child feel terrible about his stuttering, and, you know, how could you do this? And so they wanted to show that Lidcombe is safe, and that's, you know, often where you start trials of a new drug or something. And so Woods, Shearsby, and those folks did a study in which they used the Achenbach Child Behavior Checklist, and there's a Q, something begins with Q, like Q something, it's an attachment scale. And it showed that, you know, not only was there no disruption in the parent-child bonding, but also the child was feeling much better about himself, and so Lidcombe actually was having a benign effect, which of course you wouldn't be surprised at if it fixed the child's stuttering. Then Harrison et al. Started to do some early dismantling studies, and so Liz Harrison, I call her the Earth Mother of Lidcombe. She's just an amazing clinician, so calm, and I have a video that goes with my book in which it shows Liz Harrison with the newest, a new mom from, a mom from Argentina who's just moved to Australia. And so not only is the kiddo who stutters there, but the kiddo's older sister is there. And so Liz has to both teach the mom how to do therapy with the kiddo who stutters, but keep the daughter entertained. And she's able to do all those things, and you just see this amazing effect over a period of weeks. But anyway, Liz Harrison was responding again to this feeling like, do you really have to do anything with a stuttered speech? Isn't that, you know, like, couldn't we just leave that out? And she was able to show in this study that if you left that out, it would take longer and you wouldn't get as good outcomes. Let me just make sure I hit everything there. Yeah, I actually think this is probably one of the most important studies that I'll be talking about. Sue O'Brien published last year with the Australian Stuttering Research crew a study that showed it's almost as effective when used by just community clinicians who maybe had been trained or maybe they just read about it. And what they found, you know, they compared, they looked at outcomes 9 months after. And 9 months was chosen because that's what the RCT studies had done. So they wanted to compare these community SLPs' outcome with what the RCTs had shown you could expect after 9 months. So they were able to show that the community SLPs had a better outcome even than the experts if they had been Lidcombe trained. And it was interesting about the fidelity. This is a good article because they talk about their fidelity checks, and then they quote a number of different people on, you know, like what is really important to consider in implementation studies. And so I know what it was. One of the things that happened was that the people who had been Lidcombe trained kept their kids in therapy longer. Stage 1 was longer because they were going by the manual in terms of getting that absolute stable fidelity. And the people, there was a number of other things, like the sessions that the non-trained folks used were not as long. They're like half an hour as opposed to 45 minutes to an hour. So they're able to identify things that were not resulting in as good outcome. Then the Lidcombe folks did a study of the delivery by telehealth. And so, as you can imagine, it started out by the telephone and progressed to Skype. And this latest study by Skype was RCT, 49 kids, all within, you know, relatively circumscribed area, but some of them randomly got webcam and some of them came in face-to-face. And so they were absolutely equal in the amount of time it took and what the outcomes were. And by the end of it, when the parents who got face-to-face found out that the other parents had gotten webcam, that's 2/3 of them wanted that they would prefer that, because they didn't, have to come into the clinic. And so also it's been shown, let me see, I may not have a chart here for this, but this is where we started to realize you don't have to see the parents every week. So quickly, I'll just go over our research. Patty, I don't know what your clock says, but my clock says I've been going for 25 minutes. Is that about right?
No, I have that you have like 1 minute left.
Oh, so you started when okay.
But I'll give you 2 minutes.
Okay, it's a deal.
Can we negotiate that?
And the Jaguar? So in any case, we were able to show, we looked at our first 15 kids 2 years after they'd gotten fluent, and found that our results, when it was done by grad students, were at least as good as the Australians, and that pretreatment severity rather than frequency, which the Australians say predicts outcome. And then we have a study that's under review right now, and it's really the first study to show that girls do better than boys, which is not surprising. And I think there's this, confluence or joining of natural recovery factors and the fact that girls just respond better to treatment. And I won't spend any time on this because I don't really have time, and it's probably confusing, but we're trying to dismantle the Lidcombe also. And there has been some suggestion that it makes kids more fluent because their language is less. So a couple of our students, I said I'd mention their name, Hannah and Alyssa. A couple of our students have shown that the language of kids who've been going through Lidcombe doesn't change any more than the language of controls we're just measuring for the same amount of time. And they also looked at what they called parent conversational pressure, in terms of parent MLU, type token ratio, and when a parent utters a statement that requires a response. So that didn't change over the course of Lidcombe. So, and then Danner has done some work showing that fortnightly treatment is more effective than weekly treatment, in terms of efficiency, and fewer sessions are required. So the last slide is that we're about to get our act together to do some implementation work looking at the EEE, the Early Essential Education SLPs in Vermont, who deal with age 3 to 5. And some of the challenges we think we're going to face is arranging the initial training so that they're not only doing Lidcombe, but somehow we can get them on board as feeling part of a team in which they will be gathering data and we'll sort of all be working together. And then what has been mentioned several times, that is the support, the follow-up support by people going out to their place and doing the listserv. How do we standardize data collection? What are the scheduling difficulties that they'll have in their environment? But because of this conference, I've really seen that the adaptation of the strictly manualized Lidcombe is something that we have to do with the SLPs and perhaps with the administrators. So that's a picture of the University of Vermont. Thank you very much.